All right, so this is the role of orofacial myofunctional therapy in the dental field. Oh my gosh, I can hear myself. Perfect. Okay, here we go, y'all. So my name is Renata Nehme. I've been a registered dental hygienist since 2010, and I became a certified orofacial myologist earlier this year. So I am originally from Brazil. I was born and raised in South Brazil. I moved to the United States when I was 14 years old as an exchange student. I was here for a year, and I fell in love with the U.S. I've always been in love with America. Most people don't know this, but when I was 4 years old, I used to cry every time I heard the national anthem. So I came back. So I lived here for a year when I was 14. I came back when I was 18. I graduated from Armstrong Atlantic State University in 2010. Georgia Southern just bought them, so it's no longer AASU in Savannah, Georgia. I met my husband while I was still in high school, and now we have two beautiful children. And yes, both were tongue-tied. In Brazil, breastfeeding is the norm. So needless to say, I am a huge breastfeeding advocate, and this is what got me into this journey of myofunctional therapy. As I was taking my first class, I realized what a greater impact I could make in my patients' lives. I was immediately drawn in. I knew that this is what I needed to do. I officially opened my business, Myo Moves, in 2018, and I operate mostly online. So these are just some objectives at the end of this course, since it was supposed to be a super serious course. So what are orofacial myofunctional disorders? They're patterns involving orofacial musculature that interfere with normal growth, development, and function of orofacial structures. Inadequate muscle function can lead to a disruption in proper orofacial development. So form follows function. The skeletal structure will form and mold depending on the function of the muscle. A good example is Stephen Hawking. He had ALS, and we all know that ALS causes a loss of muscle control. It doesn't affect bone. It's a muscular disease. It's a muscle disease. However, over the years, the bone got deformed because of muscle atrophy. So ALS stands for amyotrophic lateral sclerosis. A for no, myo for muscle, and trophic for nourishment. So the muscle atrophies because there's no longer any nourishment. If you guys cannot see the screen well, please let me know. But there you go. I hope that I figured it out. Let's see. All right, awesome. Next slide. So what is the prevalence? It's believed that at least 25% of the population is walking around with a myofunctional disorder. Tongue thrust or reverse swallow or atypical swallow affects at least 30% of school-age children. Think about all of your patients who are receiving orthodontic treatment or present with malocclusion. At least 60% of those are believed to have a myofunctional disorder. And the next time you see a patient with TMD, temporomandibular joint disorder, you will look at them differently, because almost 98% of those are likely to have a myofunctional disorder. How insane is that? So what is orofacial myofunctional therapy, or also known as orofacial myology? I usually tell my patients that it's like physical therapy for your face. So OMT consists of therapeutic exercises to strengthen and to re-educate facial and tongue muscles. We work increasing muscle tone, strength, and promoting muscle memory. Every patient is different. That is why just following a list of exercises will not benefit every patient. We need to understand what are the patient's limitations, muscle involvement, symptoms, medical history, and address each one of those independently with an individualized therapy plan. I was actually just thinking about this the other day. I don't think I have ever had two patients with the same plan, the same, treatment plan at all. Everybody is slightly different. In myofunctional therapy, we have 4 main goals. The first one is to establish proper tongue rest posture. What is that? Ideally, your tongue is supposed to be touching your palate front and back for 24 hours a day. Why is that important? Because applying pressure for 4 to 5 hours a day on a skeletal structure will impact how this structure forms and develops. Think about orthodontics and what they have to do to widen the palate or move those teeth. It is constant light pressure applied to those structures to move the teeth. Now we ask ourselves, why after somebody get their braces off, why do the teeth move? Right? Because there is constant light pressure being applied to the teeth by either the tongue or the orofacial muscles, the lips and the cheeks. So if there's still constant light pressure, those teeth are going to keep moving. Also, proper tongue posture helps protect your airway. You cannot breathe through your mouth with your tongue on your palate. So let's try it. Open your mouth with your tongue low and take a breath in through your mouth. Now we're going to try the same thing, but suction your tongue to your palate, open your mouth, then try to take a breath in. You simply can't. The air has to go through your nose. The second goal is nasal breathing. The flow of air will also impact skeletal structures. The tongue growth, guys, is genetic, but the orofacial skeletal growth depends on proper function of breathing and occlusion. I learned this with my wonderful friend, Brazilian doctor, Rosanna Albertini. She actually developed an incredible palatal expander, which is a myofunctional palatal expander. It promotes proper tongue position and lip seal. It's called the TASA, T-A-S-A. She's going to actually be coming to talk to us very soon over here. So think about, I like to say this to my patients, I like to break it down in a way that people can understand. So think about what the wind does to mountains over time. How can the wind change the shape of a mountain over time? So we are doing the same whenever we are breathing with our skeletal structures. So think about somebody, if they're breathing all day long, if the breath is shallow and it is strong, that is going to do something. Even if your nose breathing, you might be breathing wrong. That's going to eventually over time change the way that you look, or as you are developing is going to make sure that you look a certain way. So usually those people have longer faces, and we're going to get into that in a little bit. Our third goal is lip seal. We also call this lip competency. So naturally, our lips are supposed to be closed and sealed at any time we're not talking or eating. Your lips will help keep your front teeth from sticking out. They are the best orthodontic retainers, like Linda D'Onofrio says. Our closed lips will promote nasal breathing. Our number 4 goal is chewing and swallowing. Muscle dysfunction contributes to an atypical swallowing. Our digestion starts in the mouth. If what's going on here, it is not ideal or healthy, the rest of our digestive system might not respond how it's supposed to. I have seen patients with severe tongue restrictions who are always constipated, for example, and they go to the doctor and they're given, Miralax or some other type of medication. They just have to be on it for the rest of our lives, their lives. And it's not, there's other options out there. There's other things that we can be looking at if this is the issue. So this is one of my favorite things in the world, breastfeeding. And I say this all the time, the mechanism of breastfeeding aids on the development of orofacial structures because it involves proper suction, swallowing, and breathing. when children breastfeed, and if you have watched a child breastfeed, sometimes they will sweat. It takes a lot of effort. They are exercising. So they're exercising those muscles. It's like those babies are going to the gym every single day. Just the action of breastfeeding, they are making their orofacial muscles in their tongue strong and increasing tone. Now, for many reasons, some moms cannot breastfeed, or some babies cannot breastfeed, I would say. Several different reasons. And I'm not here, of course, to judge anybody. But let's say a child drank from a bottle for 6 months. As soon as they hit those 6 months and they're ready for solids, those muscles do not have as much tone and as much strength as a child who's been breastfeeding for those 6 months. So whenever you introduce solids, you might see some issues. This child might have a difficult time chewing or lateralizing that food with the tongue. And those children a lot of times will choke more often. So they do accept soft food and purees a little bit better than solids. The tongue is the supporting structure to develop the maxilla. So we're going to talk a little bit about orofacial development. If the tongue is low, there's an imbalance of intraoral pressure. The amount of pressure exerted by the cheeks counteracts the pressure from the tongue. If the tongue is not up there, the force of the cheeks can push the maxilla in, creating a possible crossbite or just a narrow, high vaulted palate. The question is, as a child who is growing, if this force is creating a high vaulted palate, is that also contributing to a deviated septum? Because the roof of the mouth is the floor of the nose. So I'm just going to leave this here. It's so important for us to ask questions and think about these things. I really don't think there's any research proving this, but it's something that we should all be asking ourselves. And this is why early intervention, y'all, is so important. We need to catch myofunctional disorders as early as possible to diminish the amount of time they stay in this dysfunction. We need to eliminate oral habits before a patient starts orthodontics because they work against each other. Oral habits have been implied to contribute to the alteration of craniofacial and dentofacial structures. And some of these things that I'm saying, I have on the screen where they came from. Some oral habits such as mouth breathing, digit sucking, lip licking, pacifier use, nail biting, and prolonged bottle feeding may be accountable for the underdevelopment of the maxilla. Oral habits are also responsible for the disorganization of the facial muscles, which are used for breathing, eating, and speaking. So during orofacial myology evaluation, facial and neck muscles are carefully observed to address strength, tone, and function. And throughout our treatment, these muscles will be reorganized to reach optimal function. If any negative oral habits are present during treatment, no progress will be made because the habit will keep driving form and function in the opposite direction. In the dental field, we can tell if a 2-year-old will need braces. Why aren't we doing anything about it? Most orthodontists will only see these children when they turn 12 or they have lost all of their baby teeth. Why is it okay to have these children mouth breathe for 12 years? The skeletal structure is getting worse and worse by the day. It would be amazing if orthodontists were all well versed in how breathing and lack of chewing can cause malocclusion. It is our responsibility to help these children grow healthy. There's so much more that we can do as dental professionals. And that's why I'm so passionate about sharing this with my colleagues. Patients trust dental hygienists. They spend so much time with us. Several of them become our friends. We can be observing and educating the patient when they are in our chair. And I understand that we already have we're super busy and we have so many duties as a dental hygienist, but it doesn't take long to notice if a child has bags under the eyes, a constant runny nose, or dry lips. And I'll get more into what else we need to be looking at. We're already looking in the mouth. We can already tell if this child has a high vaulted palate, a narrow bite, a cross bite, a tongue tie. We can refer a young patient to seek help when they are young. We see healthy patients twice a year. There isn't a better professional to be screening these children and sending them to the proper professional. So what does research say? And I got a couple of these quotes. I'm just going to read them to you. Patients with oral habits who are seeking orthodontic treatment due to malocclusion are advised to eliminate any possible oral habits prior to the completion of treatment. A patient is likely to relapse into a new malocclusion if oral habits are not addressed. When bad habits are present with dysfunction of orofacial muscles, orthodontic treatment is not enough to solve occlusion problems. Myofunctional therapy done in conjunction with orthodontic treatment in these cases can lead to a successful therapeutic outcome. So let's talk a little bit about nasal breathing, because this is how it all starts. Breathe in and out of your nose day and night. The nose has three main jobs. It filters, it warms, and it humidifies the air you breathe in. If pathogens go in through your mouth first, they land on the tonsils, creating an infection. They bypass your body's natural filter. Breathing in and out of your nose creates something called nitric oxide. Nitric oxide is antiviral, antibacterial, and antifungal. It's also anti-inflammatory. It shrinks the turbinate so we can breathe better. It increases CO2 storage, helping hemoglobin release oxygen into your blood. By that, it increases IQ, concentration, memory, energy, exercise endurance, all due to more oxygen being released into your brain, your muscles, and your organs. It's also a vasodilator. This photo here, you guys correct me if I'm wrong, it's either by Dr. Mew or Patrick McEwen. I think it's Dr. Mew though. Breathe through your mouth as much as you eat through your nose. We hear this phrase all the time, and some people hate this phrase because we can breathe through our mouths for a reason, and it's a survival mechanism. If we cannot breathe through our nose, then yes, you gotta breathe through your mouth. But we should not. If we can breathe through our nose, we should not be breathing through our mouth. Mouth breathing is a compensatory mechanism triggered primarily by nasal respiratory failure. Breathing primarily through the nose is essential for the growth and development of the orofacial muscles. As Mary Billings says in one of her studies, airway obstruction can be brought on by allergies, sinus infections, enlarged tonsils and adenoids, deviated septum, sleep disorder breathing, and the list goes on. To encourage prolonged nasal breathing, it is recommended to reduce allergens in the home. With my patients, I advise, for example, pets staying outside of the bedroom, changing bed sheets often and washing them with a hypoallergenic laundry detergent, reducing or eliminating the intake of dairy, nasal hygiene. Everybody should be doing nasal hygiene every day. And a visit to the ENT and an allergist to rule out any other problems. There's so many causes of mouth breathing, but some of the most common include allergies, allergic rhinitis, I think is the first one, food sensitivities, enlarged tonsils and adenoids, chronic nasal congestion, respiratory infection, asthma, deviated septum, nasal polyps. So it's important for us to work in a multidisciplinary team and with a multidisciplinary approach, because obviously myofunctional therapy alone doesn't do much. I need to work with an allergist and an ENT and an orthodontist, sometimes a speech pathologist, occupational therapist. I'm gonna get there in a second. Sleep disorder breathing is an umbrella term for several chronic conditions in which partial or complete cessation of breathing occurs many times throughout the night, resulting in daytime sleepiness, fatigue, and the type of fatigue that interferes with a person's ability to function and reduces quality of life. Symptoms may include snoring, pauses in breathing, and disturbed sleep. I hope that this plays. This is just an example. Let's see if we're going to get it to play. It's difficult sometimes to even watch. There's so many of these videos out there. Nobody should be sleeping with their mouth open. Nobody should be making noise while they sleep. Breathing should be quiet. In that first video, you even see her stop breathing for a second, and then she moves and wakes herself up. And that's usually what we do. We move. We move and we change positions. Or our significant other is elbowing us for us to move and stop snoring. But none of this is healthy. There's so many of these videos out there. And it's about 18% less oxygen going into the brain. Over time, this will reduce IQ. So, dental professionals, how do we screen these patients in the dental chair? As soon as you get the patient from the front, we can already start looking at how this patient is talking. Check if the patient is moving the jaw everywhere while they speak, side to side and back and forth. Those usually are TMJ patients. If you see somebody speaking and their jaw is going everywhere, oh, they're going to have TMJ issues. Ask a patient to swallow while they're smiling. And I'll do this for you guys here. And look, watch for any muscle straining around the lips, chin, and neck. So if people cannot swallow only with their tongue, they will do this. They use their lips because of the intraoral pressure. You don't have that tongue helping you. Ask if they feel refreshed in the morning after waking up. A lot of young women have to have coffee. You know, don't talk to me until I have my coffee. Do not feel good whenever they wake up. They're still tired. And a lot of women that wake up at 3 and 4 in the morning, you look at the clock, it's always at the same time. Usually that's a sign of UARS, upper airway resistance syndrome. But those are just a couple signs there. Any bedwetting or waking up to pee, a lot of frequent waking up to go to the bathroom. Tossing and turning, restless sleep, night terrors, sweating, clenching and grinding. Do they get tired easily or out of breath when they exercise? Do they have allergies? Do they eat dairy? Do they have any pets in the room at nighttime? So these are questions that we can be, cleaning the patient and talking and asking. Here are some signs, extraoral and intraoral signs, and I'll read for those of you guys who are on Clubhouse. So some extraoral signs: bags under the eyes, that's called venous pooling, open mouth posture, articulation problems, lateral jaw movement while talking, a gummy smile, I have that, facial asymmetry, chapped lips, forward head posture, shoulders rolled forward, overdeveloped talus muscle. So the chin muscle right here, all those people that are always trying to keep their lips closed, but they either have a short upper lip or a maxilla that grew down too much, you cannot close your lips naturally, or maybe even a lip tie. So they bring this muscle right here up all the time, all day long, and they swallow also like this. So exercising this muscle over and over, you're gonna get super strong, right? Some intraoral signs: malocclusion, tongue restriction, lip restriction, tongue scalloping, a high vaulted palate, wear facets, tori, exostosis, enlarged tonsils, a Malabari score of 3 or 4, and I'll show you guys what that is in a second. But these are all things that we are already looking at the patient. You know, we just didn't know that these were signs of something bigger, but now we do. So here's some pictures of some clinical findings. These are some common photos found on the internet, and then the middle one is me. I had all the signs. Look at the bags under the eyes, the bad haircut from my mom. This is so funny because I just cut Zoe's bangs last week, and I did a similar job. I used to hate this picture and talk about, you know, my mom trying to cut my hair all the time, and I just did the same thing to my daughter. Alrighty. Back to this. So grading of tonsils. We're always looking at tonsils, and you know, we have such a big advantage in the dental field because we have this amazing chair and light and instruments. So it's a lot easier for us to see these things in a dental setting. So grading of tonsillar tissue by a myofunctional therapist is simply an estimate description of the tonsillar area. It is not meant for diagnosis. Tonsils are graded by the percentage of oropharyngeal space occupied by them. Tonsils can have a grade of 0, where no tonsils are visible at all, or they can have a grade of 1, and that's this first picture right here. Excuse me, where they are barely visible in the tonsillar fossa. A grade of 2, where the tonsils occupy up to half of the oropharyngeal space. A grade 3, where they occupy more than half of the oropharyngeal space. A grade of 4, where they occupy 75% or more of the oropharyngeal space. Kissing tonsils is known as a severe grade 4, where the tonsils are touching. The tonsillar tissue can affect orofacial myology treatment by changing the posture of the tongue, the way the patient breathes, or by making it difficult for a patient to swallow. A lot of these patients will have an anterior thrust, so the tongue is usually going to be resting on the lower teeth or forward, always because they can't bring the tongue all the way back there because the tonsils are so big. And I always ask myself, how are these patients right here eating? How can they swallow anything? Those are usually a lot of kids who are picky, who will not eat certain textures. Everything has to be soft. I mean, we need to be always be curious, ask why. Why can that child not eat steak? Why can that, or not, you know, they usually say they don't like it, but it's because they choked before when they tried to chew and swallow for many reasons. But always be curious and always ask why. If a patient has tonsil grades of 3 or 4, I always refer to an ENT specialist who will evaluate and further offer recommendations to the patients. So this is a modified Malabari classification, and I already had this here and I have not changed, but this is not how I check Malabari score anymore. There's a couple different ways out there. So this one is usually done by anesthesiologists. They will ask if you have ever had surgery. They will ask you to stick your tongue out, and so they can look at your oropharyngeal space and see how easy it's going to be to intubate that patient. The one that I use for my patients mostly is called a Friedman score, and they keep their tongue in. So just like this, I just ask them to open, because that's a more natural way of where your tongue stays. So if you can see a little bit, or if you can see the whole throat, I think actually the Friedman is opposite, so I'm going to skip this. But of course, if you cannot see anything at all, that is not good. Those people are usually going to have some breathing issues. Those are the gaggers. Those are the people that we walk close to them with a bite wing and they start gagging, before they even get there. And usually that's not a survival mechanism. It is a defensive mechanism. If your tonsils are so big and your tongue is, so high and filling so much of your mouth because there's poor tone, you want to protect your airway. So if anybody gets close to you, something that is not food, that should not belong there, immediately your brain is like, nope, not happening. So that is why those people now, dental hygienists, you're going to look at these patients differently. If they gag easily with x-rays, they might have an airway issue. If you see signs, now we're going to ask for symptoms. So some of the symptoms: mouth breathing, day or night, past or present. If the patient has any allergies, asthma, past ENT surgeries, ear tubes, for example, that's something that we see in young children who cannot swallow very well. Or swallow correctly, they get tons of ear infection because the eustachian tubes are not getting drained properly. Frequent upper respiratory infections, frequent sore throat, nighttime thirst, bruxism, TMD, constipation, daytime sleepiness, exhaustion, acid reflux, difficulty swallowing, hyperactivity in children, aerophagia. Aerophagia is excessive swallowing of air. Those people that burp all the time or have GI discomfort, possible abdominal distension even. A reverse swallow pattern can contribute to the added trapping of swallowing air in the, and it can help for this condition, but correcting the swallow decreases the amount of air that is likely to be taken in through the mouth. This is an older picture by Dr. Zaghi. That's how he does his functional classification. It's not only by Zaghi, but there's so many ways of checking tongue restriction, mainly in dental hygiene school, dental school, medical school. We are taught ankyloglossia, which is this lower one right here, number 4, grade 4. And we can all tell whenever the frenum, that little tissue underneath the tongue, if it's attached to the tip of the tongue, mobility is obviously compromised in this patient. And in the dental, in the dental office, in the dental setting, we see those all the time. And we all know that if we mention that to the patient, the doctor, the pediatrician said that if there was no speech issues, we don't have to do anything. The last patient that I ever saw in dental hygiene before I went off for my maternity leave was a 10-year-old boy who had a grade 4 tongue tie. And I asked the mom, at that point in my career, I was not talking about dental hygiene as much as I was talking about airway and myofunctional therapy. But I asked the mom about constipation. He goes, oh my gosh, he has chronic constipation. And the pediatrician just recommended Miralax for the rest of his life. He's just going to have to be on that. What do you do? As a mother first, I'm like, oh my gosh. And there's, possibly his tongue restriction is contributing to his constipation. It's not activating the vagus nerve to help with digestion. It's not initiating digestion. Your tongue is supposed to push on certain parts of your mouth whenever you're eating and whenever you're swallowing. And it's all a process that initiates digestion. And if that's not happening, your digestion will be compromised. But we usually ask the patient to open up and stick their tongue up. So open up comfortably and just lift your tongue up. And then you see how much of that space is taken by the tongue. So if they can reach comfortably all the way up to the spot, which is behind the front teeth, not touching the front teeth, We usually call that a grade 1. If they can almost reach, is a grade 2. If they go about halfway, is a grade 3. And if they can barely lift their tongue about 25% or less, it's a grade 4. We also, of course, as a myofunctional therapy, that's not the only thing that we do. We're checking this patient chewing and swallowing and seeing how, other functions are working. But this is one great tool, this functional classification that they have developed. So what are treatment options? Now, depending on the age of the patient and everything that they present with, we'll either, if it's a baby, we'll send to a lactation consultant who's well-versed in tongue ties to make sure that that's not what it is, or whatever else this baby might be having any issues with breastfeeding. They can do oromotor therapy, feeding therapy, palatal expansion, speech therapy, sleep hygiene, myofunctional therapy, frenectomy, tonsils and head noise removal, craniosacral therapy, chiropractic care, CPAP, snore guard. So there's many options out there depending on what the patient needs. That's why a full good evaluation is so important. So build your own airway team. Go visit other professionals in your town. Offer to do lunch and learn. See if they're interested in being part of a study group. Get to know the people who will be in your circle, who will help these patients. And that, your team may look like an IBCLC, a speech pathologist, an ENT, an orthodontist, an allergist, an airway dentist, craniosacral therapist, an osteopath, a feeding therapist, physical therapist, occupational therapist, a chiropractor, or a sleep physician. It's important for us to visit these, our local community, our local professionals, to see who we can work with. And how do you become a myofunctional therapist? If you're interested, these are the most well-known ways to start learning about myofunctional therapy. It is a long road out there. It is lots of studying, but we are here to help. So with the IAOM, for example, the International Association of Orofacial Myology, they are the only nonprofit organization. You take a 28-hour course, usually live, but now they do have some online options. You can apply for the certification within 2 years of taking this first course. First, you do a written exam. It's about 100 multiple choice questions, and then you have about 10 essays, and then case studies and a clinical exam where the examiner will watch you take patients. For each one of the multiple choice questions and for each one of the essays, you have to read research. So the whole process, so I went through this process, it took me a whole year to do the written exam. It is not easy. It's it's a mini master's. But for each one of the questions, I had to read a full research paper. I couldn't just answer, by doing so. It's a learning process. I highly recommend it because I learned so much more just by going through the examination process. It is very difficult. It's very lengthy, but it's not as bad as it used to be. I know that some of these amazing people have paved the road for us. Some of their exams had 100 to 300 pages. So we don't have to write that much anymore. But it's an incredible learning opportunity. And you do get to use a certified orofacial myology credential. So the AOMT, the Academy of Orofacial Myofunctional Therapy, who is led by Joy Moeller, they just started with their certification process. It's a little bit different. And I am highly considering taking this course as soon as I can find some extra time, just because everybody in this field, we are nerds. I mean, we're junkies. We're CE junkies. We want to learn as much as we can. We don't ever stop. And I have heard great things about their program. But after their certification process, you can they have a 100 question examination afterwards. You got to do a case study submission. You get mentorship hours, and you get observation of 3 allied health providers, 2 hours minimum for each provider. The Colson Institute is led by Sandra Colson, and they have the CSOM letters for their certification process. They're all different. Neo Health Services, led by Sandra Holtzman. She does I think is a qualification in orofacial myology. Myo Mentor by Sarah Hornsby, and I have taken Sarah's course also. It's more of a mentoring program. It's longer. It's about, is it 10 weeks, 9 months? I don't remember. Pardon me, Sarah. I don't remember, but it was a wonderful course. I highly recommend it. And then the Breathe Institute came out with Myo Masterminds, which I want Lael, if she's on here, for her to come talk a little bit about this program, because she's taking it right now. And I really think it is the most complete program out there right now. They have different professionals teaching certain parts of it, and they bring other people to speak. So you do get exposed to a lot more. You know, even with the IAOM, you can't just go take 28 hours and I'm a myofunctional therapist. Let me just see a bunch of patients. You have to keep studying. You have to keep taking courses. Get your hands on, you know, every book that you can and every free class that Airway Circle offers. Anything that you can start just being exposed to this world and learning as much as you can, because what we can do as dental hygienists for our patients, I found out it is a lot more than I first thought I could when I first went into this profession. So I hope that more of you join us in this amazing journey of Airway and becoming myofunctional professionals. But that is it. Any questions? Clubhouse, if you have any questions, raise your hand. I'll bring you guys up. And Renata has a question. Of course, Renata. I was always the one asking questions. At what age, awesome, Lyle, at what age do you recommend to stop pacifier use? So, not every pacifier use is detrimental. I'm going to say that. Why? Because any habit, you need to ask how long they're using it for. Because that's going to tell you what intensity, because that's going to tell you if there's going to be an impact on the orofacial structures or not. So how many children out there do not have mothers and do not have the ability to nurse, you know, for several different reasons. And babies have the need to suck. First, I'm going to say that if this child or any child out there, newborn, brings their thumb to their mouth, you do not take it out and replace it with a pacifier. In the dental field, unpopular opinion, in the dental field, we learned that if this child is sucking their thumb, you pull that sucker out and you put a pacifier in, because you cannot cut the thumb out. You cannot take the thumb away, and you can a pacifier. But after being exposed to myofunctional therapy and this airway stuff, I do not believe in that anymore. A baby sucks their thumb in utero. It is normal. It is natural. It is a part of your body. Babies have the need to suck. In many cases, when there's not an airway issue, in many cases, these babies will eventually just stop, as long as the mom is able to nurse on demand. Keep nursing, let them suck their thumb. If they fall asleep, you take it out. So if a child has to have a pacifier because there's no breast available, then yes, only offer it for the baby to fall asleep and take it away as soon as the baby falls asleep. Don't let the child use it during the day. Don't let, if there's other things out there, of course, if the child is super upset and they need to calm down, they need to suck. But try to minimize the use as much as you can. There's a couple different types of pacifiers out there that we recommend, which I'm not going to get into. I'll do that another day. But then by 6 months, as soon as this child then is eating regular food, start trying to wean and take it away. Somebody, VJ asks, is it hard to find patients? Do dentists refer to you? Do your hygiene patients become your myofunctional therapy patients? So yes or no to the first one and yes to the second two. Is it hard to find patients? No. Now that you know this information, you are going to be surprised how many patients you have right now that could become your myofunctional therapy patients. It is insane. There's at least 25% of people walking out there with some of these issues. How many patients do you refer for orthodontic care? How many patients complain of TMJ issues? How many patients have wear facets? How many, there's just so many. So it is not hard to find patients. And as long as you have this information on the tip of your tongue and it's easy for you to, if you're good with dental hygiene education, you're going to be great with myofunctional therapy education and airway education. So no, it is not hard to find patients. Two, do dentists refer to you? Yes, mainly orthodontists. I do have some dentists that also refer to me, but mainly orthodontists and mainly for tongue thrusts. That's all I get, tongue thrust. There's other things that we do too, but I'm getting really good at tongue thrust. Open bite. Do your hygiene patients become myofunctional therapy patients? Yes. I don't do clinical hygiene anymore since I had my last child in the pandemic. I just haven't gone back to the dental office. But many of them, when I was still working, became my patients, and they were wonderful patients because I love my patients, dental hygiene or myofunctional therapy, and I, develop a great relationship with them, and they really do understand, especially dental hygienists are trying to help them. We are here to help you and to guide you to become better. And oh my gosh, if there's something else that I can do for you, please let me help you. Does insurance cover this therapy yet? Most insurance companies don't. Some of the codes that we use are the same as physical therapy codes, occupational therapy codes. Not the same as speech codes, but there's a few that yes. So for those professionals that can file insurance, some of them do get reimbursed. Most dental hygienists who are practicing myofunctional therapy prefer not to even deal with insurance. The amount of time that I would have to be sitting in front of the computer talking or calling insurance companies would be taken away from me treating patients. I'd rather just have fee for service, and I do give everybody a super bill. If they would like to go, fight with the insurance company and try to get something covered, yes, I help them do that. Let's see. You have to be willing. Lyle said you have to be willing to connect and collaborate and release. You will win some and lose some, but there is loss, definitely. I have been to several, or I have heard from several, dentists or even orthodontists that said, Renata, I've been doing this for 20 years. We wait until the child is 12. We extract 4 teeth if they don't have room. We push everything back. Now there's no more room for the tongue. Think about that. What is going to happen to that tongue? It's going to fall into the airway, and array of symptoms, array of issues going to come from that. But they've been doing it for 12 years. And guess what? The teeth look beautiful afterwards. We can get them straight. But we're only looking at teeth. Now, after listening to some of this, you no longer are going to look at your patients as a set of teeth that need to be cleaned, that need to be fixed. These are people. There is a whole body attached to those teeth. And everything that happens in the mouth affects the whole body. Just like if you if you hurt your knee, you're going to be walking crooked and all your muscles are going to have to adjust to that new stance. Anything that goes on in your mouth and it changes your occlusion, your whole body has to adjust to fit to that new occlusion. I mean, there's just so much. I'll talk nonstop. Oh, you meant realize it already. Wrong. Sorry. Mindy asked, what is a ballpark cost for certification? That is a good question. So nobody really just does the 20-hour course, applies for certification, and you're done. So the cost for that is a lot short, smaller. Some of these courses or any of these courses can range from $2,300 to $5,000, depending on which course you choose. You're going to end up taking more than one course. It's not going to be just one and you're, a great therapist. A great therapist is built with experience and time. So it really depends, but most of us have spent 10 to 20,000, I think. Something like that, in between those, something like that, sometimes less, but like I said, we all don't stop taking courses and studying. What is an average cost of the services you provide and length of time per appointment? So my first evaluation is an hour and a half, and after that is supposed to be 30-45 minutes. But as you can tell, I talk a lot, so I keep most of my patients for an hour. And the average of costs and services, it really varies. But I have seen a myofunctional therapy evaluation costs anywhere from $129 to $1,000, and therapy sessions anywhere from 50 to 250. I mean, it really depends on where you are, where you live, who you are, how much courses you have taken, how what you can provide to the patient. But it's net public. It is more money than dental hygiene, I will say that. And there's so many other things, but you can work with your dentist still. I think these are all the questions. Anybody on Clubhouse, if you guys have questions, let me know. Let me see if I can. I should have stopped the share earlier, but I did not want to. Let's see. There I am. Hey guys. Oh my gosh, no makeup, no filter. Let's go off of Facebook. Bye, Facebook. Thank you.